we'll go ahead and get started.
Absolutely. Well, good morning, everyone, and thanks for joining us today. One quick note, please remember that you need to be registered through the Institute of Government and all fees paid to be awarded your CPE credits for this session. If you obtain the link, but for today's session from somewhere else, then there won't be a record of you attending and you won't be able to get those CPE credits. So make sure you do that. Today's strategy is Health Insurance Cost Saving Strategies is the name of the session today. Throughout the meeting, I'll share with you the GGFOA sponsors and exhibitor page, so at your leisure, you can go out and take a look at the folks that have supported us for this conference. Related to questions, if you have any questions, simply hit the raise your hand button, or you can put a Q&A in the chat there. Use the Q&A function, actually. Place your question there, then we'll respond or have Chris to respond directly. To introduce Chris, Chris Clark has over 30 years experience in employee benefits consulting. He holds a position of Senior Vice President for Epic Southeastern Employer Services Division and is a public sector practice leader for Epic. Chris has been with Epic 15 years and specializes in large or complex local benefits consulting. So now we'll have Chris Clark.
Great. Thanks, James. Just to be check in, you hearing me okay?
You're good.
All right, very good. Thank you. Well, I appreciate everybody who was able to join the session today. A lot of you may know me. I've done a number of benefits related sessions for GGFOA for a number of years. Feel like I'm fairly comfortable in doing them in person. So this is my first time doing one virtually. So hopefully it'll go well. And like James said, I always encourage my mind to be as interactive as possible. I know, again, that means a little bit different in the virtual world, but sending things through chat, James will be monitoring that and, stop me as needed to ask any questions. And with that said, we'll launch into it. Let's see, of course, hold on. Okay, here we go. So health insurance cost saving strategies. What we're going to be talking about today is different ways, and there's a lot of them, that you can potentially save a little money, and in some cases a lot of money in your health benefits program. And we may venture off from that just a little bit on occasion into other types of benefits, but the primary focus, and as you know, the primary cost for a local government for benefits is health insurance these days. So with that said, let's see. So why is it important? Again, health costs have been going up at a pace higher than general inflation and probably higher than anything else, definitely higher than payroll for a number of years. And this is a graph going back at least to 2007, where we had costs increasing greater than 5%. And the further back we go, actually, the higher they've been. The increases have moderated a bit over the last decade. And some people would consider them more manageable at this point, but they're still rising on average, several times what inflation is running. One of the things that we've seen in this year with the COVID pandemic that we've all been dealing with is that while the pandemic first started to emerge, there was a lot of folks, a lot of experts, if you will, in the field that thought costs were going to go up in the health plans as a result of COVID. And I didn't really think that was going to be the case. And as it turned out, it wasn't the case, or at least to this point, it hasn't been. What it actually served to do was to suppress utilization. So while the actual costs for COVID, were new and went through the health plan for the most part, the everything else, anything that was voluntary or are not, not a required service, not an emergency or an urgent type of situation, people tended to delay getting those things done. There was a period of time where almost no one was going to see primary care doctors. Elective surgeries were canceled or postponed, et cetera. So the net effect of that was an actual reduction in costs for this year. For most people. And so I'm going to pause for a second here and just say, I meant to say at the very beginning that the conversation today is going to be primarily focused on self-funded health benefit programs. And in other words, a lot of these management techniques and cost-saving opportunities are really primarily available to folks with self-insured programs. If you're fully insured, you're paying a premium, and you potentially could affect that premium in the future if you're able to reduce claims. But it's much more common for these types of strategies to be considered by self-funded employers. But anyway, so back to this slide again. Looking out into 2021, there's varying predictions on what the cost change from this year is going to be. And part of that's related to how long the pandemic may continue. As you know, there's lots of information in the press about treatments that are being developed and vaccines that are being developed. And I think the prevailing wisdom sees the vaccines starting to become available around the beginning of the year, possibly a little bit sooner. But even if they become available, how quickly can there be enough dosages created to make a material impact, across a population? So those things are all going to affect what might happen in 2021, right? And so I think another part of the consideration is the care that was postponed in this year. Is that going to be gone forever, or is some of that going to come back and in the form of increased utilization, in the fourth quarter this year or into next year? So in terms of what we're seeing, James and I work a lot with large local governments in Georgia, and what we're seeing is an uptick in activity in the latter half of this year, and that probably continuing into early next year before it settles back into a more predictable range. But again, if I was guessing, I would say that the increase from this year to next year is probably going to be more in that 6% range.
Chris, can I ask you a question?
Yes.
If electives are delayed, is there a possibility that those who waited may be in worse health condition when they return to medical attention and therefore costing the employers more?
That is a good question. I guess it's all dependent on what sort of procedure they may be delaying. For example, let's say if I'm getting a hip replacement or a knee replacement, chances are that's going to cost the same regardless of how long I delay it. But if I have a condition like you're talking, that does worsen over time, it is possible that could create a higher cost. But I think on average, the overall impact of having gone through the pandemic is going to be, in a weird way, cost savings to health benefit programs. Because I think the majority, I reviewed a study of something from the past, and I won't go into it because it's not really pertinent for this presentation, but there was something that had been identified as a similar event in the past, although much more localized. And in that particular study, it was determined that about 60% of elective procedures never came back onto the calendar, if you will. They were just foregone. So with that said, let me advance. So again, it overlaps a little bit from what we were saying before, but in 2020, again, the claim costs actually were less than expected because of COVID. And again, because there was a significant stretch of time where very little activity that wasn't urgent or directly related to COVID was happening because people were being told to stay home and to quarantine. But some things happened as a result of that. So the use of what's called telemedicine increased dramatically during 2020. And telemedicine's been around, easily for a decade, possibly longer, and was gaining popularity, but granted at a slow, relatively slow pace. With the advent of the pandemic and the requirement to stay home, the use of telemedicine has skyrocketed. And the good thing about that is that it's a more efficient way to engage with the health system where it's appropriate. Right? It's not appropriate for everything, but where it is appropriate, it's more efficient than any other type of interchange with the healthcare system. So there's an expectation that that's going to continue, that folks who may have been reluctant to use that or didn't have it available to them in the past have either decided to try it or were forced to try it for various reasons and had overall good experiences and may continue to use that in the future. We'll touch on that a little bit more as we go. Again, the exception to where costs went down on just about everything was related to specific COVID treatment. And COVID treatment can be expensive. It's relatively rare that people had to be hospitalized, but there were some, and where they were, the average cost was was north of $30,000, with the potential of that going astronomically higher from there, depending on if you already had other conditions, or depending on how the disease affected you, you could potentially be in the hospital for weeks and possibly in intensive care for weeks. And as most of you know who have any responsibility around managing your plan costs, intensive care is extremely expensive, and multiple days and weeks of that can quickly create a catastrophic claim in your plan for any particular year. So again, 2021, the projected claims by folks that do those things, see it going, back up again, sort of making up what would have been the cost this year, plus a little bit of an increase from there for trend, and which is just the general year-to-year increases in medical and pharmacy cost and usage. So we've sort of broken down ways of looking at cost saving opportunities into kind of 4 broad categories. First one would be taking advantage of sort of the new normal. One of the things that would fall into that would be the telemedicine we just talked about, but there's some other things that we'll touch on as it relates to that. Secondly, long-term strategic cost-saving measures. These would be things that already exist or that have existed for a while in the benefits world, but just making sure that you're making good use of those things. They may be things that are probably already available to you as a plan sponsor, or to your employees as members of the plan, and just taking action to try and help make sure those opportunities for managing costs are being utilized where possible and where appropriate. Then we're going to talk a little bit about newer, arguably more creative types of solutions that are out there that people are taking advantage of. And then the long-term goals, looking at that and looking at where adjustments might be appropriate within that, again, that with sort of an eye on controlling cost. So the first one of those, taking advantage of the so-called new normal. Again, just to remind everyone, feel free to, I'm happy to stop and address any questions that come in as we're going, just to make sure people don't lose track of what they might be wanting to ask. So feel free to use the chat option or otherwise to get our attention and to get your question in. And then, like I said, James will be compiling those and kind of interrupt me as needed, if you will, to address any particular question. So again, talked about telemedicine. I'd be surprised if anyone on the Zoom today hasn't heard of that at this point, because it was, again, it's been around for a while. It's been promoted by a lot of entities for a while, but it was really promoted, and in a lot of cases, it might have been your only option for periods of time where you felt like it was not safe to leave your home and try to go see a doctor, or even an urgent care or emergency room situation where you might have been fearful, and rightly so, that there were other people there that might have been exposed to COVID. So you were trying to avoid that. So telemedicine in general, you can, it's a way for you to be treated sometimes over the phone, more commonly now using, you can use your cell phone, an app where you actually engage the video of a cell phone or your computer or laptop or a tablet to engage with a provider to discuss a medical issue that you may be dealing with, or somebody in your family, children, for example. Sometimes those types of engagements result in the provider referring you to a different type of solution. They may say, hey, you need to make an appointment and go in to see your doctor. You may need to go to urgent care, or sometimes on to the emergency room, depending on the situation. But a lot of times the provider on the phone or via the internet can help you and can actually prescribe a drug for you if that's what's needed, or give you advice on what to do to treat the condition that you may be dealing with. And I'm assuming it's obvious, but that creates an efficiency there that would not exist in actually going to a brick and mortar building to seek care, because you don't have all the ancillary staffing and, again, the building and whatnot that has to be paid for as a part of that. James, I noticed you reappeared there. Do you have a question for me?
I did. I just want to ask you a question based on one of the comments in the chat, and I know it's near and dear to you, related to telemedicine somewhat. There's a comment about the city of Columbus using an on-site health and wellness center to help contain cost. If you could just shed some light, your thoughts on the implementation of on-site clinics and health and wellness centers.
Okay, I'll go ahead and answer that. It does fit in at also in another spot in the presentation. I don't know if it's listed specifically as an item in there, but it was definitely something in my mind as I was putting this together. But I'm a large fan of on-site health and wellness centers, sort of more generically called on-site clinics. I think the term clinic may be off-putting to some people, so the health and wellness center or some other variation of that is a common terminology to use. In some of the employers that we've done projects for and whatnot, we've actually done clinics or helped with clinic strategy, marketing, et cetera, for folks like Forsyth County, City of Atlanta, Cobb County. We currently do some work with Augusta, Richmond County, and Henry County as well. And we've actually reviewed strategy for others that, for reasons, may have decided to wait or to not pursue that particular strategy. It's not necessarily for everybody. I believe that for it to work in an optimal way, you need to be a certain size and have a certain commitment to the strategy for it to work. But again, the general concept, I believe, is very valuable. And when we get to a future slide, I'll talk even a little bit more about that. But thank you. Thanks for that question, and hope I was able to answer it. But even with the on-site clinics, the folks that we work with that have on-site clinics or health and wellness centers, if you will, those had a drop-off in usage. As a lot a lot of employers were closed for some period of time, or were having the majority of their workforce working from home, or were trying to do some kind of split workforce arrangement with maybe some percentage of folks cycling home or office at different days or weeks, et cetera. Everybody kind of handled it a little bit differently. But when that was going on, there was also a significant drop in usage of on-site clinics for the same reasons that other, again, brick and mortar, physical locations were being avoided by people that were afraid of getting exposed to COVID. So that, a drop, maybe not as big a drop for those situations as we saw in the true private sector provider world, but still a drop nonetheless. And again, a lot of clinics instituted a telemedicine opportunity if they didn't have it already through the clinic, through the on-site clinic or their corporate staff that help support that. Another way that you can, moving forward, as folks come back to work, or if you're already at work, back to work, you can make a space in your office, say in the primary location, or maybe multiple locations of your local government work areas, where employees can access the telemedicine while they're at work, to avoid having to leave work to go to the doctor in cases, again, where telemedicine would be appropriate. And we've seen and perhaps encouraged in some cases employers to offer incentives. We have open enrollment happening or about to happen for most of most local governments that are on calendar year plans. You may want to encourage, or you can encourage telemedicine by offering some sort of incentive, maybe a $25 gift card or something of that nature. It wouldn't take anything large, to encourage people to download the telemedicine app that might be tied to your particular program. So in health plans and what we call TPAs, or third-party administrators, that would be what you would call the carrier or administrator that manages your benefit program, your health benefit program if you're self-insured. But also if you have an insured arrangement, which I'm sure a lot of the folks on the Zoom today do, you should have these types of services I'm about to talk about baked into your program. You should already have them. And you should hold your provider, provider in this area, your vendor, or the carrier or TPA, accountable in some way for tracking the use of these, for assisting in communicating that they're available, for targeting, not in a data privacy violating way, but trying to make sure people that can use certain tools know about them, et cetera. Anyway, they should have these types of tools that I'm about to talk about baked in to the services that they provide, and you should be able to get reporting on how much they're being used and whether or not they're effective. In other words, what are you saving me, by helping me manage the health of my employees? So one is transparency tools. Transparency tools would be tools where folks might be considering, we talked earlier about an elective procedure, a shoulder replacement, or, that's kind of one of the easier ones to think of, but it could even be things like an advanced imaging type services, a CT scan or an MRI. They should have tools available where you can find out how much that costs in different, from different providers. But cost, obviously, especially, thinking about healthcare, is not the only thing to worry about. You want good quality at a reasonable cost. So here where I'm saying provider location, I'm talking about locating a provider. Let's say, if again, you need to have something done, but you don't have a particular person identified to do it, you can help locate different providers that do that particular procedure through, again, these tools that all carriers and TPAs should have available for the plan members today. And again, helping find a reasonable cost provider that is good quality is what employees and members of your plan should be encouraged to do. And some folks incorporate certain types of, again, incentives to encourage folks to do that. Diabetes management is another area where, James was asking an earlier question about if people are delaying care for, due to COVID, could that have resulted in some type of increased cost down the road? And the examples I gave, it wouldn't, but if anything like a chronic condition was going on that required regular engagement with a provider to manage that, and those types of engagements got skipped or postponed, that could very well lead to a higher cost situation down the road. So again, all carriers and TPAs should have some type of chronic condition management program. Diabetes is a big issue in the Southeast, especially. Our populations tend to experience that at a higher level and more severity than other parts of the country on average. So it's important that your healthcare vendor is managing that where possible, and that the information to access those types of programs is being made available. Wellness programs is another area where, again, every carrier and TPA are going to have something available, and you should be able to utilize those services. They may not be exactly what you want for your people, and if they're not, that doesn't mean that you just ignore it. It means that you may need help from your broker or consultant or otherwise advisor to help utilize those services that are available through your existing relationships with vendors, to make sure you're leveraging that as much as possible. Another thing that's very common in that space is getting some type of subsidy from your TPA or carrier to help defray the cost of any wellness program. And I'm going to pause for a second here and just speak about something that we've also had some good success with as it relates specifically to local governments, and that is in the wellness space. You can also take advantage of other community resources if you're really looking to build a comprehensive wellness program and strategy. And what I mean by that is, many cities and counties have a local college of some sort, and it could be a technical school, it could be a junior college, but they almost all have some type of culinary program, for example. Healthy cooking type of programs are very well received by employees and can be very impactful in terms of improving health. A lot of colleges, even again junior colleges, may have nursing or similar programs, medical related. So there may be some things you can tap into there. We've had success getting reduced rates at local gyms or YMCAs. Your local hospital, a lot of times, could be a partner, should be a partner with you in your wellness program, et cetera. So again, those are things to think about in that regard. Medicare transition, that comes into play, obviously when folks reach age 65, but beyond that, if somebody has a particular condition, especially end-stage renal disease or ESRD, you become eligible for Medicare after a certain period of time with a chronic condition. So, or a debilitating, disabling condition is what I meant to say. So you should have some type of service or some type of assistance available to look for those opportunities, and look for opportunities where somebody might be eligible to transition to Medicare, because that can save your program money and probably provide even better benefits for that person. Then mail order RX, again, is something that's been around a long time, but historically that's been a little bit of savings for both the plan and the member when that's utilized properly. So next, we're going to talk about some long-term strategic cost-saving measures. So again, are we getting the most out of our medical or pharmacy administrator today? And on the medical side, again, they should have some strong cost containment measures that already exist. And again, it would be useful for you, at least on an annual basis, to meet with your carrier or TPA and have them go through what these programs are, explore opportunities that they can, that you can make sure that employees know about them, preferably that your TPA or carrier is actually identifying folks through their claims and reaching out to them to make sure they know that certain things are available. And similarly, disease and so-called chronic condition management programs, again, these are things that have been around for a long time. It's just their effectiveness hasn't always been as as good as it could be. And again, a lot of these things, unless your carrier or TPA partners is really being held accountable for demonstrating, that they're implementing these to the best of, that they can, you may not be getting the value from them that you are effectively already paying for. Again, I think customer service, specifically now as it relates to technology, is a big deal. So this has more to do with employees being able to get the most out of their benefits to make sure that they know everything that they have coming to them, so to speak, and that they're utilizing those, that they're getting the answers they need when they're trying to access care or trying to understand their options as it relates to dealing with maybe a newly diagnosed condition for them or their children. And again, how to access that information through different means. There's always been the toll-free telephone number, but more and more folks now prefer to use online solutions, maybe an online chat type of service, et cetera. And then is your medical vendor, if you will, again, carrier or TPA, keeping up with things, as they become available? Is their telemedicine option now, as good as it should be? There's a number of different types of management tools and techniques. The transparency we touched on, again, some of these things have been around, but they've gotten better over time. And is your vendor keeping up with the enhancements and improvements that you should be able to have coming to you? On the pharmacy side, I'm going to pause here and kind of go into a little more detail on a couple of things. But are you getting the best discounts and rebates? So folks that, again, are self-insured, you should be contracting independently or separately for your pharmacy deal. That doesn't necessarily mean you're carving it out or using another provider for it. It just means that that's a specific component of how you financially contract for your overall health benefit program. There's the biggest cost driver in health benefits today is specialty drugs. So on the pharmacy side, and specifically the specialty drugs in the pharmacy program. So, but with that said, there's been a lot of improvement, if you will, on the available discounts and especially rebates in your pharmacy as it relates to your pharmacy benefits. And so if you haven't revisited that in a little while, even if you're mid-contract, it would behoove you to revisit that and work to try and get that deal improved. And a couple of examples, we had a metro Atlanta County we worked with about 5 years ago where, I'm trying not to call out what we do specifically, but this, any sort of good person in our industry, as we onboard a new client, a new local government, we're going to collect a bunch of data. We're going to review your existing contracts and benefit program. So about 4 or 5 years ago, we were onboarding a metro county and looked at their pharmacy contract, and it was not where it should be. And we were successful in renegotiating that deal mid-contract. It's common to have these in 3-year contracts, and they were a year and a half into the deal, and we were able to renegotiate it midstream. More recently, just this year, we've onboarded a large consolidated government and ran into a similar situation. So, and again, renegotiated mid-contract. The first example I was talking about was about a $400,000 annual savings to the local government. The one this year was even bigger. It was more closer to $2 million of annual savings. Just again, for taking a look and asking the right question. And again, there's a little bit of you have to play a little bit of hardball with that. But again, experienced people in our industry know how to do that. So I strongly encourage, if you take nothing away from this, other than one thing, would be to relook at your pharmacy deal and have someone that has expertise in that space. Take a look at it compared to what the best out there sort of current deals are. And again, the situations I was talking about, we didn't change benefits, we didn't change vendors, we didn't change anything. So as far as the employees saw no change at all. The only thing that happened was the local government saved money. On a related note, not specific to health benefits, another area where we're seeing opportunity for savings is life and disability insurance. So again, if you haven't marketed that in a while, or even if you have, again, that may be another area. It's another area where we've had success, again, mid-contract, renegotiating the deal, because those dollars aren't as big as what you can find in the pharmacy benefits. But again, it's low-hanging fruit. And I think everybody should be working, especially in this time when, due to the effects of COVID, your revenues may be under a little bit of pressure. So being able to find low-hanging fruit, cost savings, I just can't imagine anybody wouldn't want to do that. Another area as it relates to pharmacy, there are vendors out there, and there's actually just websites out there. There's a website out there called GoodRx. That's probably going to be the only vendor name I actually call out during this presentation, but it's almost become ubiquitous in how it being effective and being basically free to use. But it has options out there where employees can look for coupons that they can use towards offsetting their out-of-pocket costs for pharmacy benefits. There's also related to, this kind of ties into the second and the fourth bullet here, specific to specialty medications. There is a lot of vendors now have popped up, and I'm looking at this for several local government, probably 4 different local governments throughout Georgia right now. This strategy I'm about to explain. There's a number of sort of third-party vendors out there now that specialize in helping you and your affected employees find financing for these newer, extremely expensive so-called specialty medications. A few years ago, this started happening a few years ago, and some of the initial efforts in that regard were maybe met with sort of varying levels of success and maybe had some unintended consequences, if you will. Again, that's a longer story than this presentation would allow for, but just say that strategy has been refined, and it can be very effective now in terms of finding either the manufacturers themselves or different types of sort of foundations or charities, if you will, are make money available to help pay for these high cost medications. The theory behind it is that it's intended to help folks who, or it's primarily intended to help people who don't have insurance. But these third-party vendors now have found ways to leverage that to benefit people who do have insurance and the insurance plans behind them. So my best guess is that the opportunity for this type of savings is not going to last too much longer because more and more people are starting to do it, and there's only so much money to go around. But I think it would behoove you again to also investigate that as an option and see if there's a way to integrate that into what you're doing. A different way of saying that is if you can save a few $100,000, this year, next year, and maybe the next year, but it goes away after that, or would you not do it just because it's going to go away at some point? Or should you take advantage of the few years of savings that you can get? So I think most of the folks that I deal with would want to grab that money while they can and worry about the it going away down the road. So I've noticed James pop back in. That probably means he's got a good question for me. What do you got?
Yeah, Chris, for these type of strategies, how much lead time and maybe a high level strategy specific to employee communications? How do we know, and how much time do we need to let the employees know that these types of changes are occurring?
So good question. I'll expand on the question just a little bit and also say, are we limited to a particular time of year to introduce these sorts of things? And the answer on the part I added is generally not. It's generally not something that has to happen at your annual plan renewal date. A lot of these can be added mid-year, and maybe even better to be added mid-year because you can then focus on the rollout of this new strategy without it being clouded by all the communications that you need to do for open enrollment. And but in terms of lead time for employees, it's a great question, and it probably varies a little bit from strategy to strategy. But you can do kind of a soft launch. The majority of these are going to be voluntary at the employee level, meaning that maybe they don't have to utilize this new opportunity or strategy. So again, those options could be a softer launch. It would be difficult to go back to each individual one I might have mentioned and say what the lead time might be for that. So I apologize if that might have been something to include. But in general, I would say, not a lot. Just I'd say 4 to 6, at most 8 weeks lead time. And again, it's something that you can introduce for the most part at any point during the year. And so, how you want to roll it out, when you want to roll it out, and, you're going to have a lot of good knowledge of your own employees and what your culture or customary ways of introducing benefits information is. So, I would assume you would want to do some combination of written communication as well as maybe some group meetings where you can Zoom and or in person if you've got the opportunity to do that. But again, I'm expecting in a few months, the real sort of clamp down on how we do everything is going to loosen up a bit, and we'll still be more careful than maybe we were historically, but it won't be like we've been dealing with the last 8 or 9 months. So hopefully that answered the question, but just to make sure, I'd say anywhere from 4 to 8 weeks in terms of a rollout would be fine. So let's see, okay, so I think I did mention the specialty and the stuff related to that. And then the third bullet here is something, that's just, you should always do. And I think it's kind of become pervasive throughout. Very few people are reluctant to generic opportunities where that makes sense. But, and most people are somewhere between 84 and 89% generic utilization now in their plans. So there's not a lot of additional opportunity there, but again, it's still something that never hurts to make sure that message continues to be pushed out there. Let's see. So helping employees in the next phase, what I'm talking about here is where folks have some type of life event that might occur where they might be able to take advantage of a different type of health coverage. And primarily I'm talking about Medicare. But there are services that, there's certain services probably available through your TPA or carrier that you have today, or otherwise maybe EAP program. But I'm sure that almost everybody has something in place that helps folks with these sorts of situations listed here on this slide, with sort of understanding what, how did I transition into, say, Medicare coverage, or in some cases Medicaid, or children's assistance, where it might be, where you might qualify for it. And that, again, primarily is something triggered by age, but sometimes it can be triggered by income, whereas maybe one spouse loses a job or passes away, and suddenly the family income drops below levels that might allow people to qualify for additional assistance. End-stage renal disease, again, is something that after you've had it for a certain amount of time, you're eligible for Medicare. And by taking advantage of that, again, in a lot of cases, it saves money for the employee, and it also definitely saves money for the local government in terms of your costs towards your plan. So again, if you should try to explore, ask HR, what resources do our folks have today? If you deem that they're not that good, there's actually third parties out there that do a incredibly good job at assisting with these situations. And again, a lot of them do it with a guaranteed ROI. Their primary existence is not cost savings, but it's sort of a byproduct that they have cost savings in what they do, and will actually guarantee like maybe a 4-to-1 return, or at least a break even. Which again, if this is helping your employees, why would you not add something that at least breaks even for you and makes things better for the employees? So looking at some newer creative solutions now, next. A lot of folks have heard the term carve out, where that, as it relates to health benefits, that's where you might contract in general, say with a insurance carrier to administer your plan. If you're self-insured, you're not actually using their insurance, you're just using the administrative functions, and then you pay your own claims. But within those administrative functions is various cost management tools and techniques, and you can contract for them. You can get the complete package, or you may find that there are third parties out there that do certain pieces of that better. And better in this case primarily means ways that save you more money. And some of the things traditionally that have been around for, and carved out frequently: stop loss insurance, your pharmacy benefits, wellness programs. But there's also things like diabetes management, with what we call CM and DM, care management and disease management. We talked about transparency and decision support. Again, those should be baked in, and those are the sort of things they should be baked in as something that's available to you. You may determine that you can outsource that piece and get more value for it. But again, you should at minimum be making sure that these programs are utilized and reported on, so you can see whether or not they're working and at what level they're working for you and your employees. Again, transparency, decision support, organ transplants. Sometimes when you're self-insured and you're fearful of having expensive organ transplants hit your plan, you can actually buy insurance that sort of carves out just the organ transplant piece. A lot of stop loss carriers sell that now. End-stage renal, again, a lot of times that the management of that is carved out to a specialty entity, or you may again carve that out for a cost savings. That some folks may have heard the term direct contracting. That's where you take a particular piece of your benefit plan, your health benefit plan, and contract with an entity to just provide that for you, presumably at a deal that's better than what you would get through the network that you have. So what I mentioned on the left side there are things that have been around for a while, and a while there meaning, you know, at least 5, and in most cases more than 10 years. The trending ones, you know, may have been around for 5 years, but have kind of gotten more attention of late. So again, radiology, or just in general imaging, that would include things like CAT scans and MRIs. It's there's a lot of opportunities now to sort of directly contract for that, where you would get a better price in exchange for you know, an arrangement that sends the majority of your covered members to that particular provider. Similar concept as it relates to orthopedics and musculoskeletal. That, though, also includes some new therapies that are available that may not always be covered in your benefit, in your traditional benefit program, but might be more efficient overall than sort of the traditional approaches to services in those areas. I know that sounds a little like I'm using code words there, but if somebody had more interest in that, we could talk more about it, but I just didn't want to lose too much time on that one. Physical therapy, primary care here, again, that was where I was going to talk about the on-site clinic or the on-site health and wellness center, which we already kind of touched on. But there's also variations of that now, where even if you're not big enough to have a full-on clinic, there's something called direct primary care or on-site primary care that you can look into, that you might be able to determine is a more efficient solution for that part of your benefit program. We talked about specialty RX a lot already. And family planning and maternity related, those are things where, especially on the family planning side, you know, certain employers may want to enhance their offerings in that area. That might include adoption assistance, et cetera, things that a health benefit plan, health insurance per se, might not necessarily deal with, but you may be able to offer discounts or help in that area as well. So moving on from there, you talk about what we sort of generally call RX tourism. This is kind of another way of trying to save money, or looking to save money on your pharmacy benefit program. You know, a lot of us have heard and have probably read articles about the fact that prescription drugs in the US cost a lot more than they do in a lot of other countries. And there are other countries that have been, you know, not necessarily far away countries, Canada, for example, that have you know, a healthcare system, you know, where the quality and sophistication is not that much different than what ours is. So folks are looking into opportunities of getting prescriptions, at least higher cost ones, you know, via mail order from, say, Canada, for example. And so there's opportunities out there today that, where vendors assist with making that happen for you. Secondarily, or in addition to that, there's higher cost conditions, again, that you might have where, again, you're taking chronic conditions where you're having to take maintenance drugs, taking medications over long periods of time, possibly for life, that are expensive. A lot of times when you're trying to get treatment for that, the actual prescription, if you're going to get the drugs in some countries, you actually have to have a prescription from a local doctor, a doctor in that country. So in cases like that, sometimes people are even going out of the country to see a doctor to get a prescription that they can then fill, again, for a much cheaper amount. Obviously, that's a little more involved type of strategy, but it is being done in some cases and it results in even covering the cost of the travel can still result in some pretty significant savings to the plan. Reference-based pricing is another, and I believe maybe the last area I was going to touch on today. Some of you may remember, I think a couple of years ago, possibly 2 or 3 years ago, we actually did a presentation at the conference just based on reference-based pricing, or primarily based on that anyway, and talked about it for, again, the better part of an hour by itself. This again has been around for more than a decade, but it's gotten more uptake each year over time. It's still a pretty small, way less than 10% of folks are taking advantage of this for good reasons that we'll talk about in a minute. But the concept, I wanted to spend a minute talking about what the concept of reference-based pricing is, because I think it's a fascinating strategy. It just, again, unfortunately has a lot of thorns, if you will, that come along with it. If it's not managed really well, can end up being a PR nightmare for whoever it is that introduces it to you, or introduces it into your employer's benefits plan situation. So again, the strategy is it's based on the idea that the biggest payer for health services today is the CMS, the Centers for Medicare and Medicaid Services. And within that, if you were to break that down, it's really the Medicare cost. The Medicare program is the biggest payer of health insurance claims across the country in terms of dollars. So, but they have what they pay is based on kind of set pricing. And there's a very sophisticated way they determine what they're going to pay for stuff. But at the end of the day, the federal government establishes what those prices are going to be. Again, they do a lot of study around what it costs to provide certain things, the cost structures of hospitals and doctors, et cetera. But again, they set the price, and the price that they pay tends to be substantially lower, especially for hospital claims and larger cost claims, substantially lower than what your insurance companies pay, even with your best in class networks that you might have access to, or that you probably have access to. So what does that mean? If you stop and think about it, if you're like, okay, so, people are telling me I'm getting a 60% discount off of some retail price, which is kind of arbitrary in reality. But I know that when somebody gets the same service and they're covered by Medicare, their cost is less than half of that. How do I tap in to that deal? I want that deal. And part of that is what, some of the previous slides we talked about, opportunities to kind of get people into Medicare, or, taking advantage of Medicare pricing where you can. Basically what this strategy does is it says, we're, at least for hospital claims, we're going to tell the hospital what we're willing to pay. We're not just going to pay whatever bill they send, because those amounts are outrageously high in some cases, or they seem to be, or at least compared to what Medicare pays for the same thing, it seems outrageously high. I'm going to pause for a second. I saw James pop in, and was that with a question, or are you just getting ready to wrap me up?
Now, I have a question for you. Does reference-based pricing increase your premium cost up front?
Does reference-based pricing increase your premium cost up front?
Uh-huh.
It shouldn't. I'm not aware of a situation where it would. What you may see, and what the person asking the question may be thinking about, it should come with more expensive administration cost, because the folks administering this for you, if they do it right, are going to be doing a whole lot more work for you than what your current vendor would be doing just with a PPO or HMO type network. So I'll jump back. Hopefully that answered the question. But again, at the end of the day, the administration is a small fraction of the overall cost. The claims should be 8 to 20 times what that is. So, paying a little bit more on going from 5% to 7% for administration is not a bad deal if your claims are going to go down 20 or 30%. And that's what people that promote this strategy will tell you and will claim, and when we'll be able to show you in effect. But here's the issue. Well, let me finish explaining what it is, and then I'll talk a little bit about why it can be challenging. So again, I was talking about, it sort of started with people realizing that Medicare paid dramatically less for the same services than even the best discounted networks were providing. So people said, we need to change the paradigm here. We need to, instead of just letting a hospital send a bill that we have no way of justifying whether it's fair, why don't we do what Medicare does and effectively kind of objectively determine what's fair, and then we will pay that, and then we'll fight with the hospital if necessary to get them to accept that as the proper payment. And I saw James pop back in. Is that?
Yeah, you're going right in the right direction. This is a great question, and I know that you and I have worked on this before. Do you think county government should have more informative learning sessions in helping employees approaching retirement age, needing to know more about Social Security and the additional options available for those 65 and over?
Yeah, and you can probably answer that better than me, but yeah, absolutely yes. And again, one of the things I talked about, I think it was on a wellness related thing, I was talking about taking advantage of local resources that already exist and that might be willing to provide discounted or free services for you. Same goes for this question. Again, you probably have existing services that you may not just be utilizing to their fullest, but whether you do or not, you can also get, and James and I have been successful doing this for some counties or some of our local government clients, I guess, to say it more fairly. Getting actually people out from CMS, from Social Security and from Medicare to do sessions for either for employees or for the HR team or the benefits team, if you will. And frankly, we'd be happy to put something like that together. They have a team of people at CMS in Georgia, based in Georgia, that just do that. And they are underutilized. I know, again, for example, everybody's familiar with Delta Airlines. We've done some stuff there where those folks have been involved. It seems to be larger employers that tend to tap into that, but there's no requirement that it has to be. And, I think it's something that folks could get together on a regional basis and have people come out. But yeah, the point being that there are third-party services out there that do an excellent job with this, but that comes at a surprisingly affordable cost, but a new cost nonetheless. Whereas CMS, and I guarantee you have existing resources that you just may not be taking full advantage of that would provide at least some level of service in that area. So let me just jump back. I know, I'm going to be up against the clock here before I know it. And I think this is my last material slide, if you will. So I want to make sure we get this out, and then we'll move on to the wrap up phase. But again, the point of the RBP, if you will, is that we're going to utilize the work that Medicare has already done to establish what a quote unquote fair price is. And then we're going to pay more than that. And then we're going to, in effect, kind of negotiate or work with the hospital. And again, generally you have to have legal resources involved, not your legal resources, but the legal resources of the vendor that you partner with for this strategy, to work with the hospital and explain to them why paying 2/3 of what they billed you is the right number, and why they should not come back after your employee for the balance of the bill. And if you think the logic is very sound, the way it works in practice is way more complicated. But the logic is you accept payment from CMS all the time and you're good with it. I'm going to pay you more than that, and you're going to tell me you're not good with it. So again, that's sort of like the argument, if you will. And, again, I think if you're a payer, especially, you find that to be highly logical. If you're the hospital, maybe not so much. So, what you don't want to do, the concerns are that, again, it's complex, it's complicated for employees to understand what it is that you're telling them is going to happen. Employees are going to be fearful that if the insurance doesn't pay everything that the hospital tells them it should, they're going to come back to the employee and expect the difference. And that will happen. And that's where the legal resources of your vendor are going to come in and fight that situation. There's various other things that can be confusing. It might have a negative impact on your employee recruitment and retention. Again, because a lot of times people are going to say, well, what kind of benefits do you offer, and how does that work? And it just it's possible that people that will find out that there's this sort of weird, complicated thing that you're doing with your health insurance, and may not want to have any part of it. So there's a number of things that can make that tricky. But I think, again, the concept is sound, and at least from the perspective of the payer side, which is who we represent. So I can tell you, though, I've been told that there's 2 or 3 local governments in Georgia that are doing this. I don't know who they are specifically. I've talked about it with clients. I've never put it in with any of my clients, but my firm has put it in with other entities, with varying levels of success. So the savings part is going to happen. The employee disruption is also going to happen. And, it just depending on how well you're able to manage that is going to be the primary factor in whether or not you see this as a success or not. I've heard of a lot of cases where people have tried it and walked away from it, went back to the traditional method where they just weren't able to make it work. But again, if you're in a very desperate financial situation, this is an interesting thing to consider. So with that, we're back to any other questions or that might be out there. James, any other things we wanted to try to get in?
Yeah, we have one more question. Have you experienced where employees are provided with any home equipment that would help with their biometrics, such as blood pressure cuffs, for successful virtual office visits?
Yes, definitely yes. And again, a lot of times, where that's more common is folks that have particular conditions where they need to monitor blood pressure or other types of vitals, if you will, on a more regular basis than you can't go to the doctor every day, unless you have a really critical situation. But right, so there's certain things that don't make sense from both a time and a cost perspective. So yeah, I mean, so I've seen it. I would even argue it's very common for those sort of situations. I've also seen wellness type programs where, blood pressure cuffs might be provided. I don't know that I've heard of situations where they're provided to everyone. I've not run across them directly. I would look into, how much it's, like a lot of this stuff, it's a cost benefit type analysis you would run through. If you have a vendor, James and I have worked with folks where their carrier has been willing to provide certain things, and we've been able to leverage that. But we haven't done a situation where everybody gets a blood pressure cuff necessarily for free. Because another thing with that is, you want to make sure the reading is done properly and whatnot. So, at least even if you did do something like that, I wouldn't do that at the exclusion of utilizing, professionals, at least once a year type of thing. But yeah, we have seen things where, whether it's blood pressure cuff or something else, it might be I'm blanking out over here, James, but like the watches that monitor
Fitbits.
Fitbit's what I was trying to think of. Things like that. We have had clients that we've worked with where those have been made available, to folks across the whole employer. So that is not a super unusual thing. I just haven't personally run across the blood pressure cuff for everybody option, but it could certainly be done.
Very good. And I think that's all for the questions. Melanie, if you could post up the evaluation, I think we'll do a couple of quick trivia questions if possible. I'm going to give you guys a couple of trivia questions. First response in the chat here, $25 gift cards will be distributed by GGFOA. So the first one to answer the question wins. How many counties are there in Georgia? How many counties are there in Georgia? Looks like Cheryl, we're spinning here. Derek Brown looks first. Very good.
I like the 26 answer though. That should get a bonus.
Yeah. All right. Second question. What is the largest county in Georgia by land size? John Redmond has it. Ware County.
All right. Well, you may want to go back and look at that list to make sure. I think maybe Melanie should be the arbiter of the winners, because a lot of them came in instantly.
Yeah, they came in. Like the lotto numbers.
So I think James, wouldn't it be good for you to provide a prize for everyone who got it right? Wouldn't that?
There you go. Hand delivered at that, mask and all.
Hand delivered. All right. Well, hey, before you wrap it up officially, I wanted to thank everybody for attending our session. I hope it was helpful. I prefer to have it kind of as a discussion, and obviously this sort of setting makes that not work quite as well. But I appreciate everybody who had questions and shared stuff through the chat, and hopefully we touched on all of them. If there's anything that we missed, James and I both are available. We take questions from folks all the time that we aren't necessarily engaged clients with us. So, if anybody thinks of something or didn't ask something or wanted to clarify something, we're more than happy to answer such things. And we both have fairly easy email addresses to get to. Mine's chris.clark, standard spelling, at Epic Brokers, EPICBROKERS.com, and James is james.ford at epicbrokers.com. We both have relatively simple names. So again, thanks a lot and appreciate everybody's attention. And James, I'll let you do the final wrap.
Thanks. Just as a reminder, in the weeks following the conference, participants will receive your CPE certificates based on the sessions attended and as reflected in the Zoom participation reports. As a reminder, you must be registered and all fees paid through the Institute of Government to receive these credits. Chris, thank you for the great presentation this morning, and thanks to EPIC. Thanks to the 84 attendees that spent some time with us this morning. We really appreciate your time. And don't forget to complete your survey and visit the GGFOA exhibitor page as well. Thank you again and have a wonderful day.
Thanks a lot. Take care, everybody.
Thank you, everyone. Great presentation, Chris. Thank you, James.
Thanks a lot.
Absolutely.